guys have to recognize when you get a board question, what is it that they're asking you? Are they asking you about a hypertensive emergency, or are they asking you about chronic hypertension management? Because that's one of the things that people usually make mistakes. Tomorrow he asked me to come to talk about nephrology, so we can talk about like cases, nephrology cases. I do. For those of you guys that are new, I've known Dr. Ben-Zur for a very long time. I work in the office for 3.5 years, and he's been my mentor. I'll tell you later the things that he was able to do for me. But anyway, I just wanted to get started with business because we have a lot of topics to cover. If you have questions, feel free to interrupt. This is very interactive, and I usually use clinical cases to go over the high yield facts. Anyway, who likes history? You guys like history or not so much? Not really? Am I too old? You love history?
I like it, but I
Yeah.
don't like it.
Well, I love history.
I don't like American history.
You don't like American history?
I like European history.
European history? That's true. I didn't find the...
Yeah, Civil War
I was just
and all
not-
that.
Oh, yeah.
Do you like Colombian history?
I love Columbus. I can tell you a whole story.
The ex-president just got a Nobel Peace
He got the Nobel Peace Prize. Yeah. Like Israeli president who recently passed away, he was also awarded the Nobel Peace Prize.
So it was Obama.
It's a bit Obama, yeah. Very good. So you guys, whether or not you like history or you don't like history, you should know that President Roosevelt, he died from intracranial hemorrhage related to severe hypertension. And it's a funny headline. Back in the days, they came out of the clear sky, said the doctor, at the time, but it wasn't really out of the clear sky. If you take a look at his blood pressure pattern, the guy was like completely out of control. And historically, we have like several important historical dates, like the D-Day, the Normandy invasion of the Allies in France. You can tell that his blood pressure was spiking dramatically. Systolic blood pressure was 250. You can possibly imagine the amount of stress this poor guy was under. And then right after, probably around April of the following year, that's when he ended up getting the massive stroke and he died. So the reality is that this didn't happen out of the blue, like the physician back in the days said that they weren't expecting it. Nowadays, we've done tremendous progress in terms of preventing this kind of scenarios. However, your job is very important in recognizing and to, more importantly, when you're doing your residency, to emphasize good follow-up for these patients. Because if somebody presented to the ER with a hypertensive emergency, if you guys don't take action, guarantee that person is going to come back. And maybe the next time that the person comes back, he's not going to be so fortunate. So we're going to talk about like the proper disposition of these patients and in management. But I think it's a beautiful slide, and it was published in an elegant paper in the New England Journal back in 1995.
While I'm still here, I know last week somebody had a question about Sophia. I won't mention the last name. But, who was it? Erica. Yeah. So we have this young lady who actually has very difficult to control hypertension. She's on 7 medications for blood pressure.
Wow.
Clonidine every hour or 2 hours, and just maximum doses of everything that she can tolerate.
Mm-hmm.
And her blood pressure still spikes up to 220, and then half hour later it's 130. But she spends a lot of time in the 220 range.
So she spikes. She has like paroxysmal hypertension.
Mostly I would categorize that. She's got a lot of different.
Have you guys done a secondary hypertension workup on her? Everything isn't remarkable? Yeah, so there's an entity called pseudo-pheochromocytoma, which is typically seen in females, and they resemble the biochemical syndrome, but they don't have the biochemical evidence of catecholamines excess in their blood. And it's a complex physiopathology, but it's one of the reasoning behind is that they have this paroxysmal hypertension mediated by the sympathetic nervous system, and although the patients may not say it, anxiety may play a role. And it's important that number one, it's important that you guys do it as a diagnosis of exclusion. So you rule out everything. Like tomorrow, we can talk about a little bit about hypertension because I think I already covered hypertension with the other students. But one of the important things you need to know is that when you're confronted with hypertension medicine, your job is to get a good history and to cover the ABCs, what I call pseudo-resistance. Is this person taking her medications? Is this person following or adhering a sodium-restricted diet? Is this person obese? If that's the case, you need to recommend weight reduction. Is this patient physically active? So those are important things. And then you start thinking about CRAS. You start thinking about like, okay, what else could be going on? Definitely a person that young with such a high blood pressure requires a secondary hypertension workup. On your boards, you may get a question where when a young woman is taking oral contraceptives, like estrogen-based oral contraceptives, so just make sure that you recommend referring her to GYN. Don't stop them because you're gonna get it wrong. Yeah, GYN. Yeah, yeah, exactly. And but that may be, inquire if she's taking hormones. Inquire if the person is taking any over-the-counter medications associated with severe hypertension, NSAIDs, decongestants, Afrin, Sudafed. People use them and they don't tell us, so you need to inquire about over-the-counter and prescription medications.
How many patients would you say out of like the severe hypertensive that you're just not able to control?
These days,
Yeah.
if they're really compliant, unless you have a genetic syndrome and you need to give them like a Miloride because they have Little syndrome, I don't think there's such a thing. If they're compliant with the sodium restriction, there's not such a thing. Probably a dialysis patient is a different story because those guys they're very volume dependent, so they may. But even those that are volume dependent, if they adhere to the sodium and the fluid restriction, you can control everyone. So this person that has this paroxysmal hypertension, I would think about pseudo-pheochromocytoma as playing a role. And there's two important aspects of the management. One is disclosing, what your thought process is, because you need to explain the patient, in a non-confrontational, non-judgmental way. Like, listen, I think this is what's going on. And secondly, and I'm saying that because if you tell them that and you say, oh, it's all in your head, they're gonna leave you for sure. They're gonna seek for any other physician. And secondly, beta blockers, they seem to they seem to work very well for these kind of patients. I know we always hear about beta blockers being weak blood pressure agents, but for some patients actually they work pretty nicely, especially for those patients with pseudo-pheochromocytoma. But like, you can universally control everyone with medications that we have. You have to really start thinking about compliance. Is this person really taking the medications? Some patients don't take the medications. They're ashamed to tell you that they're not taking them, or they're looking for some sort of secondary gain. Now that I'm doing a lot of hypertension, I realize that a lot of these patients, they come to me, they're not really secondary hypertension per se. They're more like pseudo-resistance or non-compliance with medications, because I need to do the whole homework. I need to call the pharmacy, I need to find out when was the last time they pick up the medications, just count the pills when they come in. I tell them bring the pills. Sometimes I count the pills and you'll be surprised. So it's a little, you need to do the legwork, but it's possible to rule out pseudo-resistance. Like, you can try, for this person, you can try and order a 24-hour urine sodium, and that way you know how much sodium she's having in a 24-hour period. You guys know what the recommendation from the American Heart Association?
2000.
It's 2,000, the less the better. For some patients with severe heart failure, we recommend even less than that, 1,800. But you can actually measure it. It's tangible. Another thing you guys can do is to do a 24-hour ambulatory blood pressure monitoring, because there is a entity called white coat hypertension, and that's a clear indication to wear a monitor to rule out white coat hypertension. That way you can see the daytime blood pressure, the nighttime blood pressure, and whether or not the patient has a dipping pattern. Because remember, when we sleep, the systolic blood pressure usually drops about 10 points. And some patients with severe hypertension or with concomitant sleep apnea, they have a non-dipping pattern. And we know from clinical studies that those patients carry a higher risk. So the targets should be more strict, attaining the targets. So I think those are things to consider. Maybe that person needs an ambulatory blood pressure monitor just to figure out what's going on at home when she's not in an office setting. And but every time I hear this this sudden onset of paroxysmal hypertension, you guys have to think about FIO for your boards. The good news is that FIO is not common in clinical practice. I've only seen 2 cases. And the other thing is pseudo pheochromocytoma, which is totally resembles it, but it's totally unrelated to catecholamine excess.
Is that related to a patient having other comorbidities to get the pseudo-pheochromocytoma?
It's primarily like these patients in cohort studies, they have a lot of anxiety, like emotional. I have a patient that she has that syndrome, and there's a lot of trauma. She had a lot of history, like the child tried to kill her, and like things that I learned down the road. Because she was doing stuff. It was a very challenging case. She was doing stuff that she wasn't telling the doctors. So she once got admitted to the hospital, and she was profoundly hypotensive. So we couldn't figure it out why. So I sent a diuretic screening, and she was taking all sorts of things that I didn't even prescribe. And on the second hospitalization, we found out that she was actually she had a bag with her at all times, and she was in the ICU getting pressor support. She was actually getting inotropic agents to bring her blood pressure up. She was trying to self-harm. She was a Munchausen syndrome, basically a factitious disorder. It's not intentional. It's not malicious. It's not like the person with malingering that's trying to do something for a secondary gain. This person really had a factitious disorder, and when she was able to talk to the psychiatrist, the guy in a meeting that we had, the guy disclosed to us that there was a lot of trauma that I didn't even know, because I don't have the time or the credentials to kind of explore these kind of aspects of somebody's life. So trauma, and that's why I say that stress can cause severe hypertension. Totally true. So, but for patients like this, these challenging cases, make sure you guys explore trauma, and pseudo pheochromocytoma is always possible. Okay, can you help me read the clinical case?
51-year-old man admitted to an outside hospital. Chief complaint is sudden onset of left side weakness, severe headaches, slurred speech, and left facial droop. Blood pressure 260/172. Head CT scan showed right basal ganglia hemorrhage with shift. HPI intubated en route due to declining mental status. Past medical history of hypertension. According to the wife, patient was non-adherent with prescribed medication. Outpatient medications and allergies are not available. Family medications positive for hypertension and CVA. Exam shows blood pressure at 196/130, positive for left dense hemiparalysis. Hemiparesis. Hospital day 2, patient had dilated right pupil, emergent right frontotemporal craniotomy, and evacuation of clot. Subsequent hospital course, difficult to control blood pressure, and pneumonia. Renal MRI showed right kidney 8.1 centimeter with 3 renal arteries, left kidney 12.2 centimeter with 2 renal arteries. Patient transferred to rehab.
So what's relevant on that renal MRI? What's the normal size of an adult kidney? It's about 10 to 12 centimeters. The taller you are, the bigger the kidney. The smaller you are, like a small female, probably it's okay to have like a 9 centimeter. 8 centimeter in a male is definitely abnormal. So every time you see a smaller kidney, you have to think about either something happened to that kidney, maybe it was an obstructive insult, maybe it had a stone that was blocking, caused severe hydronephrosis years and years before and causing that, like atrophy of that kidney. Or you think about some sort of like severe ATN, maybe the patient has pyelonephritis. Most patients remember, like, yeah, I had a severe kidney infection, I was hospitalized for 2 weeks. If you ask, you get a good history. But also you have to think about vascular. You have to think about like atherosclerotic renal artery stenosis is definitely in the differential. Or if it's a younger person, we think about fibromuscular dysplasia. So I was just explaining to their students that atherosclerotic renal artery stenosis happens in the proximal third versus fibromuscular dysplasia usually happen in the mid or in the distal third of the renal arteries. So they may give you a renal angiogram. So that's why I'm sharing this with you, because the site of obstruction matters where you see the narrowing. But typically the boards are not going to give you like a gray zone. They basically they show you a young person with the distal obstruction and pretty consistent with fibromuscular dysplasia. So this guy has pretty abnormal right kidney findings. Does he have that? Maybe. We're going to talk about that. Okay, so read the question for me.
What is the primary reason for hypertensive emergency in the USA today? 1. Renal vascular disease, fetal chromocytoma, non-adherence to anti-hypertensive medication, hyperaldosteronism, or erythropoietin.
What do you think is the right answer? Renal vascular?
Non-adherence.
So the most common cause is non-adherence. The second most common cause is non-adherence. The third most common cause is non-adherence. So you have to think about that because in medicine, what makes you a great doctor, the difference between an okay doctor and a great doctor is that you always think about what do you think is more likely that I'm dealing with. When I was teaching you guys nephrology, I told you ATN, 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 ATN. But ATN means many things. So the reason is finding out why this patient has ATN. So in hypertension medicine, non-compliance is very common. In fact, pharmacies, they do studies about compliance and adherence, and they have all the tools, the technological aids. And non-compliance is quite common in clinical practice. It can be up to 25 or 30%. And don't ask me why, because the patients go in and they tell you I'm taking my medications, but they're not. I'm going to share with you when I was a second-year resident, I had an HIV needle accident, and the guy was HIV positive. Fortunately, his viral load was undetectable. I didn't know at the time, but it was very stressful. And the guy, he moved his leg, and I ended up like inserting the needle in my arm, and I had to take like 8 pills every day for a month. And I was so sick. My stomach was hurting me. I had diarrhea. I had nausea, and that was a very good experience for me as a doctor, not to be judgmental towards my patients, and that's one important clinical therapeutic consideration. I was just telling you guys, when you're dealing with hypertension medicine, try to find a regimen that is reasonable and that is simple. If you prescribe a medicine that needs to be taken 4 times a day, your patients are less likely to take it. I don't care what they tell you. Research shows that they're less likely to take it as prescribed when you're putting a complex regimen in your patients. So when you have severe hypertension, you have to think about non-compliance. So another teaching point from this clinical presentation is that this guy with such a severe hypertension for sure needs a secondary hypertension workup. That's what I'm trying to say. So it's important that you guys work them up, but you always think about what's more common, and more common is non-compliance. So hypertensive emergency, the definition according to the JNC8 report is severely elevated blood pressure with signs and symptoms of acute organ damage. It requires hospitalization, it requires IV medications to try to correct it. That's the definition of hypertension emergency. So I didn't give you numbers, right? I'll tell you why. So a hypertensive urgency, I'll tell you later why. A hypertensive urgency, in the other hand, is severely elevated blood pressure without any signs or symptoms of acute end organ damage. We're going to talk about the end organ damage. And these patients, typically, they can be managed as an outpatient, and most of them can be managed with oral medications. Is this common? Very common. Actually, we see this all the time. They come to clinic and the nurses are very uncomfortable, like, hey, I don't want to send this patient home. Like, okay, just give him some clonidine and we'll reassess. This is pretty common, but your job, if you're confronted in urgent care, is to make sure that there's no end organ damage, and you need to document very carefully what end organ damage means. I'll teach you guys how to do that. So these are the typical sites of end organ damage. CNS, we have the hypertensive encephalopathy. It can be anywhere from headaches, severe headaches, or it can be altered mental status, dizziness, like whatever new onset neurological symptom in the setting of severe hypertension, you have to assume that this is a CNS encephalopathy. But the patients can be unfortunate as President Roosevelt, and they can develop an intracranial hemorrhage, or they can develop a retinopathy. I have the classification, and this presents on my boards all the time. I don't know on the nephrology boards, but maybe on the internal medicine boards, you may get one of these questions about hypertensive retinopathy. In the heart, patients can develop acute CHF, MI, or angina. In fact, one of the most common symptoms on presentation for these patients is chest pain. And your job as a good intern, good resident, is to get a good history and to rule out things that can potentially kill someone when you send them home. So that's how you have to wear your ER hat if you're working in the urgent care in the ER, and then you have to wear your clinic hat when you're in clinic, but you always have to think about, am I doing the right thing if I'm sending this patient out? And that's why you have to be very structured and methodical. When you're admitting a patient, you think about like, okay, could this be this? Kidneys, we see patients presenting with AKI or even with microscopic hematuria. And patients, peripheral vasculature, you can have aortic dissection, or you can develop an eclampsia. We're not talking about eclampsia today because that's totally a separate topic that we can cover if you guys want some other day.
I have a quick question.
Yeah.
If someone is presenting with hypertensive, I don't know, urgency or emergency, basically elevated blood pressure, that would qualify them for urgency or emergency. So is it, if they had a pre-existing like kidney damage or pre-existing
Kidney disease.
retinopathy, it wouldn't count for emergency because it has to be an acute injury that's specifically...
It wouldn't count. Typically, patients are symptomatic. That's basically the things that you want to hear from the patient, like, having severe headaches or chest pain or changes in my vision. Those are the symptoms that most clinicians go by, because in the US we're not very good at doing eye exams. We don't have the tools, and they don't really train us well to do this kind of examination. So if you see some abnormalities, you don't know how to interpret it, whether or not this is an acute or this is chronic. But if you see the flame hemorrhages, if they show you a question on your boards with these flame hemorrhages, you better believe this is a hypertensive eye emergency. So you need to treat it as such. We're going to go over that. But most of the times you need to document very carefully. Patients have no symptoms whatsoever. That's what makes your decision. Like lawsuits prove when it comes down to discharging a patient, how you document. Okay, so they're common, like I said, it can happen in up to 1 or 2% of the hypertensive population, and we have a many hypertensive population. In the US, it's estimated that we have anywhere like from 45 to 50 million people. So 1 or 2% is it's a pretty big number, right? So we have about 500,000 hypertensive emergencies per year reported in the US, and it's higher. The incidence is higher in the elderly. Remember, we have more like stiffness and less blood vessel compliance as we age, and also more commonly seen in African Americans. I was telling you guys a week ago that there's a clear disparity between the hypertension control in Caucasians versus African Americans, and that has to do with many reasons that are biologic and cultural. So when you have an African American patient, you have to pay special attention to your communication skills, and to understand that there is a lot of distrust that has like historical grounds. The distrust on this population. I don't know if you guys how familiar you are with the experiments that they were conducting. The CDC was conducting experiments purposely infecting African American patients in the 1930s and 1940s with syphilis to see what was going to happen down the road, and that was discovered back in the 1960s that was being conducted, and it took the U.S. government more than 30 years to publicly apologize to the African American community about this horrible thing they were doing. So it's very common to have non-adherence and to have distrust for the non-African American provider, and also they have some beliefs that some of them are founded in a way that a lot of the studies have been done in non-African American patients. So I've heard from my African American patients telling me like, oh, that drug works for white people, but that doesn't work for us, and there's some truth to it. So you gotta make sure that when you work with them, number one, if you have a practice, you want to make sure that your hypertension control is the same for everyone. But I'm giving you the facts. The facts is that research shows that there is about 3 to 5% disparity gap in terms of hypertension control in the African American population. And obviously males are more likely to have a hypertensive emergency than the female population. Okay, so the common associations, most of these patients already know that they have hypertension, but it's not uncommon to see established hypertensive patient presenting to the ER with severe hypertensive emergency. Patients that then have a primary care doctor, that's a risk factor, and that's why I was telling you, as an intern, as a resident, you have to make sure that you have a good disposition plan after you're ready to discharge these patients home, because they're going to come back. And adherence, a lot of education, a lot of discussions, a lot of side effects of the medications. The more communication, the more likely you're going to have adherence. And you have to also inquire about illicit drug use, not only cocaine, but we have amphetamines and we have PCP. That stuff can cause severe hypertension. So the physiopathology, you can possibly imagine that this sudden increase in systemic vascular resistance translates into a lot of mechanical stress with endothelial injury. And that's where the pictures, I'm going to show you some pictures that I got from UpToDate. But these patients, they have like increased permeability, activation of coagulation cascade, and platelets and fibrin deposition. So you can see fiber node necrosis, ischemia, activation of the renal angiotensin system, and a lot of release of pro-inflammatory cytokines. This is a picture that I found on the internet. It's basically some of the physiopathology that there is. Nitric oxide is the natural vasodilator, and then we have and also the prostaglandins. That's why we don't prescribe NSAIDs in patients with hypertension, because we're inhibiting prostaglandins, which are the natural vasodilators, and that's the reason. That's one of the mechanistic ways of acute kidney injury, when you prescribe NSAIDs. And also be aware that patients with severe CHF or like heart failure, they shouldn't be on NSAIDs. That's an important. So in the hypertensive urgency, there is decreased nitric oxide. And in patients with hypertensive emergency, there's actually no nitric oxide and a lot of thromboxane A2, which is a vasoconstrictor, and all the cascade of events with activation, complement activation, and release of inflammatory products. And there's a lot of perivascular edema. I have a picture here to make it more interesting. So this is acute hypertensive nephrosclerosis. We used to call it malignant nephrosclerosis, but if you take a look here where the arrow is, you see a lot of this is necrosis, fibrinoid necrosis, and you can see actually like a thickening of the basement membrane. I have another picture that is more dramatic here. You can see actually the intimal thickening. That's, if they show you this picture, you think about immediately when you see this intimal thickening, think about malignant hypertension, or we call it acute hypertensive nephrosclerosis. And there is another finding that you may get on your boards, which is the onion. Have you guys heard about this onion? What do you call it? The onion skin changes, like concentric onion skin thickening of the muscular renal artery, and there's pretty much no lumen on the artery. When you see this, think about like a previous fibrinoid injury. You see this, they may give you a case of TMA. Have you guys heard about thrombotic microangiopathy? So the TMA is a intimal artery injury that can actually elicit a lot of inflammatory events, including thrombocytopenia, development of severe hypertension, and hemolytic anemia. So if they show you this, I want you guys to always remember the concentric onion skin thickening of the muscular renal artery. You can't get it wrong. And this is an IF sample of a patient with fibrin deposition in thrombotic microangiopathy. So you can see TMA in the setting of hemolytic uremic syndrome. So remember, on your boards, they may give you the typical HUS, which is more commonly seen in pediatric population, that is exposed to enterotoxic E. coli. I think it's E. coli HO157. Yeah, 157. But adults can also develop a non-diarrheal HUS, and the way you suspect it is with severe hypertension, acute kidney injury, thrombocytopenia, and you actually have a MAHA picture, a microhemolytic hemolytic anemia picture. So whenever you see a patient with severe hypertension, you have to always think about, like, can I be dealing with something with the kidneys? And that's every time I get called with a severe hypertension, I always inquire about the renal function because of that, and I always inquire about platelets, because the last thing you want to miss is a HUS or a TTP. You guys remember, for your boards, remember the 5 classic findings of TTP, like the pentad. You guys remember? Which one? Pentad of TTP, thrombotic.
Trying to make sure
Purpura, yeah.
Purpura is 1.
Usually it's altered mental status, fever,
Is hypo 2?
severe hypertension. These patients can have thrombocytopenia, and they have a hemolytic anemia. So if you see, like, they give you a peripheral smear and they mention schistocytes, yeah, so you immediately you have to connect. So patient with renal failure, thrombocytopenia, altered mental status, anemia, hypertension, you think about TTP until proven otherwise. And the treatment of TTP, the next step in the management is, you guys know? I don't want you to get it wrong. I got it wrong. I still remember. Plasmapheresis, plasma exchange. You need to remove those deficient ADAM TS13. So that's another spectrum in adults. They don't see that. They rarely see that in kids, but in adults, you have to think about, in severe hypertension and thrombocytopenia, you think about HUS or TTP. Okay, so what causes? Why some patients have severe hypertension versus others that they have mild or moderate hypertension? They've looked into many different causes. Like I was telling Dr. Ben-Zur earlier, there's some genetic syndromes, some CRAS that in reality, they very rarely changes in management, like unless you've tried every possible medication under the sun and nothing seems to work, and you give amiloride to somebody that had a mutation in the epithelial sodium channel in the distal tubule. That's consistent with a condition called Little syndrome, Liddle. But I've only seen one case of Little syndrome, and we never even sent the genetic testing. It was just like nothing worked, and we gave her amiloride, and everything changed out of the blue. Versus, some other abnormalities have been described in the oxidative stress markers and endothelial dysfunction. But I always remind students that any patient with hypertension can go into hypertensive emergency if they're non-compliant with the medications and they're non-adherence to a sodium-restricted diet. It's just the way it is. And this becomes even more important if you have some degree of kidney dysfunction. We always talk about secondary hypertension, and we should always think about renal disease should be considered part of the differential in secondary hypertension. And the example that I use to my patients is that if you have a clogged sink, and if you're putting a lot of water and a lot of salt, the water is going to overflow. The same thing happens in kidney disease. Your GFR is 40-50%. The way people eat in this country, and you don't take your medications, invariably you're going to get in trouble. You're going to have severe hypertension, and perhaps you're going to have a hypertensive emergency. So always think about, when you think about secondary hypertension, always think about kidney disease as being responsible in the physiopathology of severe hypertension. So always think about that. Okay, so can you help me with the second question, please?
Yes. What is the most common complaint in hypertensive
Emergency.
emergency?
What do you think?
Four.
Did you say chest?
So, headaches?
I'm gonna go headache.
Any other takers?
I'm gonna say chest pain because you mentioned it was.
I cheated. So it's actually chest pain. So they looked into that, and they looked into like series of ER visits in a year period. And interestingly is that the patients that presented with hypertensive emergency, these were the mean systolic and the mean diastolic in this case series that was published. And interestingly, most patients presented with chest pain. And chest pain, when you have this kind of blood pressure and chest pain, you have to bring these patients in. You cannot let them home. You need to rule out an acute coronary syndrome with serial troponin, serial EKGs. You need to rule out aortic dissection. How do you clinically rule out aortic dissection? I'm sorry?
Blood pressure in both arms.
Discrepancy of blood pressure in bilateral upper extremities. The pain, the description of the chest pain, typically a patient describes the pain as having severe pain, tearing, radiating to the back. You can hear like a de novo, when it's approximal aorta, you can hear like a de novo aortic insufficiency murmur. That requires a lot of your clinical judgment. But the bottom line, if you're working in the ER, a patient presenting with chest pain, don't send them home. You need to rule them out. You need to bring them in, you need to observe them overnight, and they need to declare themselves. But patients can also present with shortness of breath, neurological deficits, and interestingly, when this guy looked into the series, only about 3% of the patients had like headaches, and they always teach you in medical school that posterior epistaxis is associated with severe hypertension, but 0% of these patients were associated with, but they presented with epistaxis. Okay, so can you help me with the next question, please?
Hypertensive emergency is associated with a threshold BP of.
It's a hard question, right? I should put none of the above, right? Okay. So there's no specific blood pressure where hypertensive emergency can occur. So that's the take-home message. There's no such a thing as, oh my gosh, you have this number, you have a, patients can, organ dysfunction is unlikely to happen when the diastolic is less than 130, but it's still very abnormal. And the rate of increase may be more important. Remember when Dr. Ben-Zur is teaching you about pericardial effusions? So you can go into tamponade with 50 mLs if it happens very suddenly. Same thing with uremia. If somebody was not uremic, and let's say that your BUN is 70, you can actually have a seizure if it goes acutely that high. But I've seen patients with BUNs in the 170s, 180s, and nothing. I feel fine. I don't need dialysis. I feel fine. And I'm not kidding you. I've seen severe uremia and no symptoms. So in hypertension, some of the similar effect can happen actually when you have like a rate of increase that is very sudden onset. Patients can actually have an acute end organ dysfunction. And another thing that's important to consider is that pregnant patients and kids are more susceptible. Remember that the definition of hypertension in children is much different than what it is in adults. And it's complicated. You need to have like the tables to be able to make the accurate diagnosis, because there is a different definition based on the age of the children, of the kids. Okay, so the initial evaluation is you get a focus history, whether or not you have a history of hypertension, how well is your hypertension control, which antihypertensives. Remember we talk about like ideal regimens, and the definition of resistant hypertension. Can somebody tell me the definition of resistant hypertension?
After 3 medication treatment and still can control it.
Including? Including a diuretic, right?
Including a diuretic.
In maximal doses. 3 medications, maximum doses. Or if you have controlled hypertension on 4 or more agents, that's also resistant hypertension. So that's the American Heart Association definition from 2008. So you want to look at the antihypertensive medicine. Is this person getting a good antihypertensive regimen? Is he adherent to it? And when was the last time he took it? Which 2 blood pressure medicines are associated with rebound hypertension when you don't take them?
Clonidine and Destal, or
Beta blockers. Yeah. So teaching point, you never stop abruptly, neither of them, neither beta blockers or clonidine. So it's a good teaching point. Okay, you look at the social history. You can call it recreational. I don't know if this is recreational or this is poison. But amphetamines are very commonly abused in this society. Amphetamines can actually be associated with severe hypertension, but it can also be associated with renal infarction and acute strokes and acute heart attacks. And it's very, very toxic. I've seen a lot of patients with cardiomyopathy, non-ischemic cardiomyopathy, that were abusing amphetamines. is a very, very bad drug to use. Similar to cocaine, these patients can have severe peripheral vasoconstriction resulting in severe hypertension, and PCP is actually also associated not only with severe hypertension but with severe agitation, and these patients are actually, it's a medical emergency. It's dangerous to see a patient high on PCP.
Can I ask a quick question?
Mm-hmm.
You mentioned clonidine, and is clonidine given in clinic for a hypertensive urgency?
It is. It's a great medication for that purpose because it's very short acting and it's very quick onset. If you use it for like hypertensive urgency management, you can just use it in the clinic and you can discharge the patients on something else. Like, let's say you don't have labs, let's say you're seeing the patient in the urgent care setting. One of the requirements for prescribing a thiazide is to have labs before and after. You can't do that in the urgent care. So let's say you manage the patient with some clonidine and you send the patient home on Norvasc. That would probably be a good way of managing this patient showing up in the urgent care.
So there's not there's no rebound hypertension.
No.
When you're just using it in isolated.
Exactly. You're using it as needed, PRN, but if you're using clonidine for a long time, and then you say, you know what, I don't like clonidine because it's making my mouth dry, I want to stop it, and you tell the patient, okay, stop it, and why don't we start this other medication? That's malpractice. If you're using the patch, you have to change them to pills, or you can gradually go down on the patch. The patch is a weekly exchange, and it comes in 0.1, 0.2, and 0.3 micrograms. So make sure you switch them or you lower it gradually. When you're at 0.1, you need to switch them to pills so they can take them as needed. So the goal is like you're either losing weight dramatically, or you're changing the way you're eating, or you're up titrating some other agent, but you never stop it abruptly.
I was gonna ask, my dad actually had a recent hypertensive emergency and they ended up sending him home on nifedipine, and then they had clonidine PRN, and they tell him just to take the clonidine whenever his blood pressure is above this number. But I was concerned with the reflex tachycardia.
Right.
If that goes on for, what would you say is an extended period of having the clonidine be PRN?
I would probably nifedipine. How much nifedipine did they give you?
I'm not sure.
Okay. Nifedipine is a great medication. I love it. I don't know what would I do without nifedipine as a nephrologist, because my hands are tied. When the GFR is less than 30, I cannot use thiazides. I still can use spironolactone, but you gotta be cautious about it. So a lot of the therapeutic agents are limited in the setting of severe hypertension, and it works very, very well in the setting of CKD. Typically, I start nifedipine in very low doses because it's a very long-acting medication. It's an extended release pill. You're not supposed to break it. And like the point that you're bringing is valid, because if you're taking nifedipine as a solo agent, the patients can have reflex tachycardia, and it's not dangerous, but it's uncomfortable. So the patients may end up disliking it. And I almost never give it by itself without beta blocking the patients, because they may dislike it and they say, I don't want to ever touch that drug. I have a patient who the other day told me, like, I don't ever want to touch that medication, it makes me feel terrible. And it could have been avoided had they given him a little bit of metoprolol or atenolol, whatever it was. So I don't think there was any wrongdoing, but in the urgent care setting, I prefer to use amlodipine. Amlodipine is a safe medication, it's cheap. You can start them on low doses. You don't have to. Another teaching point that I want you guys to understand is that the acuity is much more different if you're having an emergency versus if you're having uncontrolled hypertension. If you're having a patient with uncontrolled hypertension, you can do more harm than good by controlling it like aggressively at the very beginning. You want to bring them, to the clinic and titrate. Instead of like, okay, I'm gonna give you a nifedipine 90. The next thing you know is like you can cause acute kidney injury from decreased renal perfusion, or the patient may feel terrible, or they can even pass out.
My biggest concern was the clonidine that they're adding in with the nifedipine.
I don't think there's any wrongdoing. No, I don't think there's any wrongdoing. The clonidine will be excellent for those sudden spikes in hypertension. But your dad should probably be switched to a thiazide diuretic. I mean, if he has normal renal function, the drug of choice should be a thiazide or amlodipine. They're based on the JNC8, they're equivalent. category equivalent. So, but if he's normal renal function, I would say switch him to chlorthalidone. Yeah. So the technique, we all know that, but I cannot emphasize or stress enough the importance of an adequate technique. Because if you have an obese patient and you're using a small cuff, you can have a falsely elevated blood pressure. So make sure you guys get the correct technique with the arm at the heart level. And that's why it's always useful to have the patients bring the instrument, and you can teach them, you can review the technique, and you can compare their instrument with your instrument, because usually in the clinics we calibrate, so we know if we're actually dealing with the correct instrument. But the initial evaluation, always assess for end organ damage and document, because that's what's gonna make a difference if you get sued. You basically assess pulses in all extremities. You auscultate over the renal artery for any bruise. You listen for rails, any acute onset of an S3 gallop, or any murmurs, like if you're suspecting aortic dissection. Neurological exam, make sure you do a mental exam. Going back to your question, how do you decide? You have to ask the patient, any nausea, any vomiting, any seizures, any headaches, any severe symptoms. And if they do have any nuances symptoms, you have to call in a hypertensive emergency. And lateralizing signs are uncommon, and when that happens, these patients, they need to be treated as an acute CVA, and they need to have all the things that we do for acute CVAs. You gotta do a stat CT, and before you give them aspirin. If there's no hemorrhagic stroke, they can use it unless they're severely hypertensive. We're gonna go over that in a minute. And you do a retinal exam. So it's a lost art. Why? Because you guys probably got very little exposure to it, because doctors are less comfortable to document something that you're not comfortable with. And when I was in medical